The chairpersons for this session, Dr. Varun Mehta, Dr. Pankaj Gupta, Dr. Sanjay Khanna, and Dr. Sumit Rangta. Can I please request you to please chair this session on hepatoradiology rounds?
So the next session is hepatologists are from Mercury, radiologists are from Uranus. What do radiology reports really mean? And it's my proud privilege to invite Dr. Raju Sharma. And uh, thank you.
I'd like to thank the organizers for giving me this opportunity. I think this very provocative topic flows directly from Sanjay's session, which was very interesting. It kind of implies that radiologists and hepatologists are on different pages and don't agree. But if we see this tagline for a colorectal clinic from southern part of India, I think the radiologists would much prefer to be on some other planet, and the gastroenterologists and hepatologists would prefer to be on Uranus. Radiology reports are read by a number of stakeholders, and this kind of Venn diagram shows that it is very important that the terminology, the lexicon, and the language is standardized so that everyone speaks the same language. They need to be clear, consistent, concise, actionable communication of imaging study results. Reports can be of different types. There can be narrative reports, which the traditional radiologist was used to, writing paragraphs of prose. But I think increasingly they're being given up for most diseases, and we are switching to a more standardized and structured format. The structured report uses a template, a more of a yes, yes, no kind of a situation for the radiologist, and then an impression at the end of the report. And there are now AI tools available which can also do the same for you. You can actually just speak sentences and paragraphs, and the software can convert it for you into a template. Before we delve into reporting per se, we also need to see that the technique that has been adopted is adequate. And typically, when we are talking of the liver, we do a multi-phase scan, do an arterial, venous, and a delayed phase, with the timings written here. And when we do an MR, we also do a hepatobiliary phase, which in the case of the contrast agent available in India, which is multi-hands, comes at about 1 hour from the injection. Just a schematic showing you, if I could have the lights down, maybe the images will project better. So we typically need a late arterial phase whenever we are evaluating a focal liver lesion where the liver parenchyma is not enhanced, the arteries and the portal vein are enhanced, and the background liver is not. The lesion, hypervascular lesion, enhances and then stands out against the hypovascular liver. In the portal venous phase, it's not just the portal vein, but the hepatic veins which are also enhanced, and now the lesion tends to wash out. The hypovascular lesions are better appreciated on this phase. And then there is a delayed phase, a typically equilibrium phase, where contrast washes out from both the liver and the lesion, except for some lesions like hemangiomas and mass-forming cholangiocarcinomas, which tend to retain contrast in the delayed phase of imaging. I'll spend a minute talking about the terminology that you will read in your reports. And typically, we use terms for the arterial phase and for the venous phase. There is something called rim arterial phase enhancement, where only the periphery of the lesion enhances. And then there is the typical arterial phase non-rim enhancement, which occurs throughout the substance of the tumor, can be homogeneous, can be heterogeneous, but is not only in the periphery. And this is what HCC shows, whereas rim enhancement is seen in mass-forming cholangiocarcinomas. And then there is, of course, a non-enhancing lesion like a cyst. In the venous phase, a lesion which is showing rim enhancement may become iso-intense or iso-dense on CT. It may wash out completely. The non-rim type of arterial phase enhancement may show washout, and the lesion may then appear hypovascular in the portal venous phase. On the other hand, lesions may retain contrast in the delayed phase, and these are the typical mass-forming cholangiocarcinomas. And because of this stepwise carcinogenesis from a large regenerative nodule to early HCC to overt HCC, we have an opportunity for detecting these lesions early in the course of disease. This is a busy slide, and I won't spend too much time on it, but just suffice to say that the regenerative nodules are hypointense on T1, hypointense on T2, and do not show enhancement after contrast. It is only the high-grade dysplastic nodule which may show some enhancement, and then it becomes very tricky to distinguish this from HCC. Let me show you some examples. These are multiple hypointense nodules studying the entire liver, and these are just regenerative nodules. The low-grade dysplastic nodules tend to be bright on T1, dark on T2, and do not show enhancement after gadolinium. It is the high-grade dysplastic nodule, which is hyperintense on T1. It's barely visible on T2 and may show arterial enhancement. Early HCC, on the other hand, may present with an enhancing nodule within the lesion, which has been called nodule within a nodule appearance, and this is how we distinguish the different nodules from an HCC. Just to show you the spectrum of a hypovascular lesion, a hypervascular lesion, and a non-enhancing lesion. So these are metastatic deposits in a non-cirrhotic liver, which are hypovascular. This is a typical small HCC, a hypervascular lesion, enhancing much greater than the background liver in the arterial phase. This is also an arterial phase, and there's a lesion seen here which does not enhance with contrast at all. The lexicon that we're going to talk of more now is the LIRAD nomenclature, because that has standardized the terms that we use for describing the focal liver lesions in cirrhotic livers or in those livers which are predisposed to developing HCC. So whenever you have cirrhosis or chronic active hepatitis or a current or prior HCC, we can apply this LIRAD nomenclature. We do not use it when the cause of cirrhosis is something like Budd-Chiari syndrome, chronic portal vein occlusions, and cardiac congestion. So how do we use LIRAD? The LIRAD categories reflect the probability of an observation being HCC and ranges from LR1, which is a definitely benign lesion, to LR5, which is a definitely HCC lesion. We first determine whether enhancement is present or not. If present, is it rim or non-rim? Then assess the size of the lesion. Is it less than 1? Is it 1 to 2? Or is it more than 2 centimeters? And finally, look for the additional major features of HCC, which include an enhancing capsule, non-peripheral washout, and a threshold growth of the lesion over the last 6 months. And I'll show you examples of all this as we go along. LIRAD is a good 50-page document. It's freely downloadable from the American College of Radiology site, and it's worthwhile going through this. This typically shows that there are different LR categories, and from 1 to 5, it basically increases your suspicion for HCC. There's a grid here. So LR1 is a definitely benign lesion. LR2 is a probably benign lesion. For LR3 to 5, we have this grid based on size, based on the presence of arterial phase enhancement, based on non-peripheral washout, enhancing capsule, and threshold growth. There are also some ancillary features that are described, which are left to the discretion of the radiologist, whether you want to use them or not. But increasingly, meta-analysis have shown that the ancillary features do not really increase the area under curve for LIRAD classification of liver lesions. So again, just a recap, this is the appearance of non-peripheral arterial phase hyperenhancement, where bulk of the lesion shows you enhancement. Non-peripheral washout, again, the entire lesion washes out, not just the periphery of the lesion. Capsule is the peripheral rim of enhancement, but it is seen in the more delayed phase. So this is different from the rim enhancement in the arterial phase because you see capsular enhancement in the delayed phase. Then the size of the lesion is important. And of course, threshold growth more than 50% in the last 6 months is a feature that is taken for HCC. And again, just to recap, definitely benign lesion is LR1, probably benign lesion LR2. And for the LR3 to 5 lesions, you have to use this grid based on size and the presence of arterial phase enhancement, along with these major features, which are capsule, washout, and threshold growth. These are the ancillary features. There's a long list. There's no need to remember this. The radiologist will do that for you. The important amongst these are the presence of T2 hyperintensity and restricted diffusion, which are features which go in favor of malignancy. You can upgrade an LR3 lesion to LR4 based on the presence of the features of malignancy, but you can never upgrade it to LR5 based only on the presence of ancillary lesions. The good part about LIRAD is that it sort of gives you management guidelines. LR1 can just be returned to normal surveillance for every 6 months. LR2, your surveillance may be at a shorter interval. LR3 again goes back to surveillance, but the interval for surveillance may be shorter than 6 months. You could do your repeat imaging at 3 months or use an alternate imaging, which means that if you've used a CT earlier, you should use an MR the next time. It is the LR4 lesion which goes to the MDT team for deciding what the further management should be. And it is this category where biopsy can play a definite role, because the radiologist is telling you that he is not very sure, but has a high index of suspicion for HCC. whereas LR5 is the lesion which is fulfilling all the criteria and therefore can be taken up for treatment without biopsy. This category of LRM is a lesion which shows you features in favor of malignancy, but not necessarily HCC, which means it shows rim enhancement essentially. And you are considering the possibility of mass-forming cholangiocarcinoma or metastatic deposits, which are rather unusual in a cirrhotic liver. Therefore, in the LRM, biopsy becomes mandatory. Then there is the category LRTIV, which is tumor in vein. And here, the job of the radiologist is to distinguish a bland thrombus from a tumor thrombus, most important criteria being the presence of enhancement, a thread and streak kind of enhancement within the thrombus in the portal vein, diffusion restriction, and luminal distension. Those are the three features that we look for, calling something tumor in vein, and that is a separate LIRAD category, and again, may need a biopsy. This is the meta-analysis published recently in Radiology, which showed that ancillary features, which is a very long list, do not really add too much to the area under curve for LIRAD assignment. Let's look at some examples. Here's a lesion, very bright on T2, shows peripheral nodular enhancement on arterial phase, shows centripetal progression. If you have this constellation of findings, this is a hemangioma, an LR1 lesion, definitely benign, does not need any further management. Here's a lesion which is LR2. This is a cirrhosis-associated nodule, bright on T1, very dark on T2 because this is a cirrhotic nodule, almost no enhancement on post-GAD images. Small, less than 1 centimeter lesion, no washout. This is LR3, can be kept on surveillance but at a shorter interval of time. Again, about a centimeter-sized lesion, shows some peripheral washout but does not fulfill all the criteria for HCC. This would fall into LR4, which means there is a high index of suspicion for for a HCC, about 74%. Whereas a definite HCC is a lesion which shows you it's larger than 2 centimeters in size, shows a non-rim type of arterial phase enhancement, shows washout in the venous phase. When we say washout, we are comparing the lesion with the background liver. That's an important point to remember. I'm not comparing the lesion with the appearance on the arterial phase. I'm comparing this lesion with the background liver, and if it is darker than the background liver, it shows peripheral washout. And in the equilibrium or the delayed phase, if you see this thin rim in the periphery, that's the capsule. So this is a lesion which is a definite HCC and can be assigned an LR5 category, and our suspicion or the likelihood of this being HCC is 100%. So this is a schematic which basically shows you what is the percentage of HCC in lesions from LR1 to LR5. So LR1 is 0% HCC, then moves on to 16% in LR2, 37 in LR3, and LR5 finally is almost 95 to 100% HCC. So these are some more lesions. I'm going to skip some of these in the interest of time. I'll just show you the LRM category because that is very important. Here's a lesion which shows only peripheral rim enhancement. This is not the kind of enhancement you see in HCC typically. This rim enhancement suggests that you could be dealing with a mass-forming cholangiocarcinoma. The other features which help you are this capsular retraction. Remember, mass-forming cholangios are lesions which are fibrous with a fibrous matrix. That is why they cause this capsular retraction, and they retain contrast in the 1 hour delayed phase. So this is a hepatocyte phase of an MR scan. And if you see this kind of retention of contrast, this means that this matrix of this tumor is fibrous, and this is LRM, likely to be mass-forming cholangiocarcinoma. Again, just tells you that this index of suspicion for malignancy and for HCC goes up from LR1 to LR5 and LRM categories. Let's see some typical examples. Again, this is an arterial phase post-CAT image, shows you non-rim type of arterial phase enhancement. Notice that even the center of the lesion shows you enhancement, although it is somewhat heterogeneous. Then it washes out in the venous phase because it is now darker than the enhancing background liver. In the delayed images, you have a capsule. So all the major features for an HCC are fulfilled, and this is a this is a hepatocellular carcinoma. So detailed report of this would read where the lesion is, what is the size of the lesion, what are the criteria that it fulfills, assignment of a LIRAD category, which is LIRAD 5, and then a recommendation at the end. Given the LIRAD 5 classification, an MDT board discussion is recommended for treatment planning for this lesion, which is definitely an HCC. So prior to LIRAD, radiologists would write things like suspicious for a possible small HCC, and you really didn't know what is the index of suspicion, what is the likelihood, versus now where we follow and you get an ordinal number like LR5 lesion in the previous case that I just showed you, suggesting a definite HCC. So an ideal radiology report should have, firstly, the patient demographics, clinical history, what technique has been followed, comparative studies, if any, the key findings, which I have just talked about, an impression and also a recommendation whether the patient should go back to surveillance protocol or should go to an MDT for management discussion. The key findings would include the background liver morphology. When you're assessing the focal liver lesion, what is the T1 signal, the T2 signal, whether there is arterial phase enhancement, whether there is washout, delayed enhancement, capsule, diffusion restriction. Then we comment on the vascular structure. What is the status of the hepatic artery, the portal vein, the hepatic veins, the biliary tree, any associated findings like portal adenopathy, distant spread of disease. Assign a LIRAD category, explain its implication also if possible, and give a recommendation. So this is a template that the Radiology Society of North America offers. You give a number to the observation. We don't call them lesions in LIRAD. We call them observations because some of them may be pseudo lesions. So the term observation is preferred. Give it a number and then give it these specific criteria and features that I've been talking about: non-rim type of enhancement, threshold growth, washout, capsule, ancillary features, and overall assignment of a LIRAD category at the end. Radiologists are prone to using terms like consistent with, suspicious for, possible, less likely, unlikely. If you're following LIRAD in this situation, you can do away with these terms. However, when you're doing other reporting for other tumors in the rest of the abdomen, sometimes you do have to use these tumors. Then it's a good idea to attach this key in your report so that the hepatologist and the gastroenterologist understand what is your index of suspicion for that pathology. There are, of course, drawbacks in LIRAD. It doesn't tell you anything about prognosis, doesn't try and predict histology. We know that there are some specific features on imaging which can predict histology. For example, if you have a patient with very high alpha-fetoprotein values with large areas of necrosis within the tumor, then you can suggest that this may be a macrotrabecular massive HCC type of histology. This is not included in the LIRAD algorithm as so far, but LIRAD is a dynamic document and they keep changing it to make it better. Then there are some features on imaging which can suggest microvascular invasion. Microvascular invasion is before there is visible thrombus in the branch of the portal vein. And these features are if you have non-smooth margins. On a T2 weighted image, if you have very non-smooth margins which cannot be identified like a pencil sharp margin, and in the hepatobiliary phase, if you have a hypointensity in the periphery, these are features of microvascular invasion. May be worthwhile adding them to the report even though they do not form a part of the LIRAD nomenclature as of now. Here's an example of another non-rim type of arterial phase enhancement with thrombus in the portal vein. The thrombus is also extending into the IVC. You can see a big thrombus in the IVC going right up to the right atrial junction. Let's assign the LIRAD category to this lesion. There's a large lesion in the right lobe. Again, does not have a clear-cut margin to it. Shows non-rim type of heterogeneous enhancement in the liver. There is washout from the venous phase in the venous phase, which means it's become darker as compared to the background liver. Shows you diffusion restriction also. So this would be a tumor in vein because here the tumor has definitely gone into the portal vein, as well as the hepatic veins and into the IVC as well. So this is tumor in vein. This is an interesting patient that we saw just a couple of weeks ago. There are two lesions here. There is one lesion here, which is relatively T2 bright, and another lesion, which is relatively very mildly T2 bright. And the enhancement category was also very different. You have a lesion which shows you rim enhancement, suggesting mass-forming cholangiocarcinoma. You have another lesion which shows non-rim type of enhancement, and we were really foxed as to what this is. We biopsied the rim-enhancing lesion, and our possibility so far is that one of the lesions is an HCC and the other is a mass-forming cholangiocarcinoma, which is a very unusual situation, but it is described in literature less than 0.2 to 3%. You can get both tumors in the same liver, an HCC as well as a mass-forming cholangiocarcinoma. These are some ancillary features. Diffusion restriction means just a very bright signal on a high B-value image. Notice the presence of extrahepatic disease in this patient. There are multiple lymph nodes. This is the hepatocyte phase of this at 1 hour, again showing you that one of the lesions retains contrast, which is the feature of mass-forming cholangio, and the other does not. So these are two distinct lesions with two distinct morphologies and possibly two distinct histopathologies as well. This is the kind of structured report that we use. We assign a number to each observation, describe each observation in detail as per the LIRAD template. It just makes it simpler for the radiologist to remember what all he has to look for, and for the hepatologist to extract information from that report instead of a narrative prose type of a report. Then, of course, you could add the T staging as well. I'm going to skip some of these in the interest of time. Then you can have tumors like hepatocholangiocarcinoma. There was some discussion earlier during the day about this, where the same tumor, part of the tumor can show you features of mass-forming cholangio, and a part can show you features of HCC. This was one such patient that we saw in our institution. Moving away from cirrhosis and LIRAD, there are some key words in a radiology report. This is a large focal lesion involving segments 2, 3, and 4 of the liver. There is this peripheral nodular enhancement which matches the blood pool. Peripheral nodular enhancement which matches the blood pool, which shows centripetal progression towards the center of the lesion, and on the delayed phase shows you retention of contrast. These are features which tell you that you're dealing with a hemangioma, and the radiologist can be so sure that this really does not need any sampling, because sampling will only yield blood. It does not need aggressive treatment. This, of course, looks like a giant hemangioma and may need treatment for simply for the mass effect and the pressure symptoms that the patient may have. So the key words in the report would be the size, the location, nodular discontinuous enhancement with centripetal progression, delayed fill-in, and retention. This is a lesion which is barely visible on T1. On T2, it is hyperintense. You give gadolinium, there is some arterial phase enhancement. In the hepatocyte phase, it shows that the entire lesion is brighter than the background liver. This set of findings tells you that this is focal nodular hyperplasia, which contains functioning hepatocytes, and that is why it is taking up contrast in the 1 hour delayed phase. And here again, this lesion can be left alone. It is a no-touch lesion and it does not need sampling if the radiologist is certain. There is an emerging role for deep learning and machine learning in the field of reporting as well, not for the interpretation, but for converting your findings into a template. There are softwares which can do that you can just be reading your report like a prose paragraph form, and the software can convert it for you into a template. Thank you very much for your attention.
Thank you for a very simplified description of a very complex subject. The house is now open for comments and discussion. Yeah, may I ask a question, sir? Any role of MR in screening for HCC in a cirrhotic patient? Like we can have some.
So there is a modification of MR now. They are talking of abbreviated MR
Abbreviated,
protocols.
right.
So there is a lot of literature appearing from North America, where they are saying you could do a study in 10 minutes. You can tailor the, MR time on the MR table is precious. It's obviously has to be allocated to other patients as well. So, but you can do a abbreviated or what has been called an optimized MR protocol, but you need to have the luxury of having MR time available to you. And so far, at least in our country, it's very difficult to use MR. Many institutions use CT for screening because ultrasound has very low sensitivity. But so far, at least, there are very, very few institutions which would have the luxury of using MR. That MR is a very abbreviated MR where we just do T2 diffusion contrast. So it's a 10 or 12 minute protocol, but yes, there is a lot of literature to that effect.
Is LIRADS applicable only in a background cirrhosis? Non-cirrhotic, this LIRADS is not at all applicable?
Yes,
right?
in a non-cirrhotic background, in a liver which is not predisposed to developing HCC, LIRAD cannot be applied.
So one question, can we get some information about possible response to locoregional therapy? Like many times these tumors have small arterioportal shunts, and these are the lesions which don't do well after TACE. So can be
So you're
some
saying before treatment.
before planning the treatment for the lesions.
So you're right, arterial portal shunt would be one such thing, but otherwise there aren't many features described which can predict. The work is being done in the field of radiomics, of course. There is a lot of literature appearing on texture analysis. Not so far for clinical use, but in the research domain, you can do texture analysis, and a lot of those parameters can predict whether the tumor will respond to treatment or not.
Thank you, sir.
But so far, not in clinical practice. Thank you.
Thank you, sir. Since we're short of time, we'll
Mr.
finish the
Jonathan.
session now. Thank you so much.